Okay, welcome everyone to the January 14th Addiction Toxicology Case Conference. Today we're focusing on naloxone. How much is too much and some other discussion. This is a joint collaboration between the American College of Medical Toxicology and the American College of Addiction Medicine as webinar partners. We have prior presentations that we've developed FAQs for, and please visit the ACMT website for a variety of different FAQs on topics presented during the Addiction Toxicology Case Conference. I'm Tim Wiegand, the Director of Addiction Toxicology and Associate Professor of Emergency Medicine at the University of Rochester Medical Center in Rochester, New York. And my co-moderator is Dr. Gloria Bishevitz, the Medical Director of Strong Recovery and Professor of Clinical Psychiatry, also in the Department of Psychiatry at the University of Rochester in Rochester, New York. And we have quite a few distinguished panelists today. Patrick Burns, Certified Peer Recovery Associate, guest expert. He is a harm reduction coordinator for Recovery Always and Hugo Doyle in Rochester, New York. Dr. Ken Connor, Professor, Department of Emergency Medicine and Psychiatry at the University of Rochester in Rochester, New York. Dr. Michael Holland, who's a clinical professor of emergency medicine at the State University of New York and Upstate Medical Center and a senior medical toxicologist, CTEH, Syracuse, New York. Dr. Lewis Nelson, Chair and Professor of the Department of Emergency Medicine, Chief Division of Medical Toxicology at Rutgers, New Jersey Medical School in Newark, New Jersey. Dr. Jennifer Plum, Associate Professor, Department of Pediatrics, University of Utah, Medical Director, Utah Naloxone, Salt Lake City, Utah, and Dr. Ross Sullivan, Assistant Professor of Emergency Medicine, Toxicology Fellowship Director, and Director of the Upstate Bridge Clinic, Upstate University Hospital, Medical Director of Helio Health, Syracuse, New York. I want to remind everyone of the 2022 American College of Medical Toxicology annual scientific meeting is going virtual this year. It's March 11th through 13th. Some excellent content. I don't have a slide to the New York Society of Addiction Medicine annual meeting, but we'll send a link around. That's have an annual toxicology panel featured at the ASAM annual meeting, which is virtual and is February 11th and 12th, Friday afternoon and Saturday morning. Some excellent content as well. None of our speakers have any conflicts of interest to disclose, and I'll jump right in to the first case, naloxone, how much is too much, myths and misperceptions discussed. Please use the Q&A to ask us questions, and we will try our best to address the appropriate ones during the presentation and respond in the Q&A as well. And this is being recorded for your review. So case one. The bystander says, I hit the patient with 3 doses of 4 milligrams of intranasal naloxone, but they haven't woken up. Do you have any more? So he's talking to EMS. An approximately 20 to 30-year-old male is found down by a bystander in an area of town with heavy street-level drug use and sales. He's slumped against a dumpster and has vomit on his sweatshirt, appears not to be breathing, and there's some obvious drug paraphernalia, including a blue hospital tie tourniquet and an empty syringe. He doesn't respond to yelling. He doesn't respond to a sternal rub by the bystander. The bystander is carrying several boxes of Narcan, and he administers 4 milligrams intranasally and calls 911. Before EMS and police arrive within minutes, he's given 2 more doses of intranasal naloxone, each 4 milligrams, because he wasn't breathing, and he reports some spasm-like activity, like he was trying to breathe, and there's foam coming out of his nose, but he did not wake up or respond like a standard overdose reversal. EMS notes some minimal rise and fall of the chest, but that the individual is unresponsive to verbal stimulation or a sternal rub. There's vomitus in his nares and mouth, and he has myotic or small pupils. His respiratory rate is documented at 4, but very minimal air flow. He's given oxygen first with big valve mask, and then intubated in the ambulance. And there's a pink frothy substance leaking from his nares and from the endotracheal tube as the patient is ventilated. The oxygen saturation initially was not reading. It's cold out, hands were quite cold, fingers with some cyanosis. But in the ambulance, as he is oxygenated and ventilated, his oxygen saturation increases into the 80s and at 90%, 100% FiO2. Patient's intubated, oxygen sets 90%. On arrival to the ED, heart rate in the 90s. His blood pressure is in the 80 over 50s. He is ventilated. He's becoming more active with neuromuscular excitation with spasms and myoclonic jerks, and he has copious tearing, and he's been incontinent of stool. And he's got the tube down his throat. His initial labs start coming back. He's got a venous blood gas with a pH of 7.01, PCO2 of over 100. The normal is 40 to 50. His lactate is 8.3, which is quite elevated, and his creatinine is 2.15. He has an anion gap of 22, bicarbonate of 18, his BON is 17, and again, we're just starting to get some of the labs back. My question to the panel is, why might this individual have not responded as a bystander expected, assuming this is an opioid overdose, like a normal overdose to the naloxone? What effect does severe hypercapnia have on the patient and the potential response to naloxone? What other lab abnormalities might one expect in this patient, other clinical sequelae? And then finally, how do fentanyl overdoses differ from heroin or traditional diacetylmorphine overdose? So Dr. Nelson, once we start out with you, why might this individual not have responded, just woken up like a normal overdose?
Yeah, thanks, Tim. There's a couple of reasons, and I usually think about it in sort of three possibilities, but there are a lot of subgroups to this. But one of them, of course, is that the patient took a massive overdose, and we don't really see that in conventional use of fentanyl or opioids. But you could imagine if naloxone is a competitive antagonist. So you could imagine if somebody took a massive dose, you might not be able to reverse it with a dose of naloxone, but that happens, very rarely in these small little clusters that you'll see. And we know this has happened on the West Coast when some of the prescription opioids were, contaminated or adulterated with fentanyl. But again, that is probably not going to be the answer in most cases. In a case like this, it's probably the hypercapnia. I mean, when you have narcosis from carbon dioxide, you're not going to wake up. And it's probably no different than being alcohol intoxicated or having a benzodiazepine on board or something along those same lines. So there's some other intoxicant or comorbid condition that prevents from waking up. And I guess, the third and probably the most prevalent issue would just be a little bit of hypoxic encephalopathy. This person obviously took a big hit. They have, pulmonary edema. So they're showing that they have taken enough hypoxia to develop pulmonary toxicity or pulmonary failure. They probably had brain failure too. So they may wake up eventually over time as their brain sort of resets itself. But those are three big reasons that people don't wake up, I think, from naloxone.
Yeah, that's great. Thank you. Dr. Holland, do you have anything to add to that? Any other reason why you might wake up, or what other lab abnormalities might you expect in this patient, other clinical sequelae?
Yeah, no, I totally agree with Lewis. He covered it pretty well. I assume they examined him and didn't see any sign of head injury as well, but that's always something to consider too, if they've had a fall or something.
Yeah, that's a good point. And you certainly slumped down against the dumpster. Dr. Sullivan, do you have anything to add?
Yeah, and I think, I think one thing that you see a lot of in bystander administration of naloxone and Narcan is that people give it oftentimes quite quick, especially untrained people or lay people. And you see now I'm not waiting maybe 3 minutes in between doses. Oftentimes, I've actually witnessed and seen people, wait only 30 seconds, 1 minute, and they're giving the second, third, fourth doses, within the first 2 to 3 minutes. Understandable for somebody that's a bystander. But I think that's something that happens a good amount, in the community, and I think expected to happen with the wide distribution, of naloxone products, to the general population.
Yeah, some good comments. There's a quote from The House of God, a famous book of fiction, that first take your own pulse when going in, just do CPR or respond. And I think sometimes, when you have an overdose like this and somebody you're concerned about apnea, time goes very quickly. The perception of time goes very quickly. So you may hit somebody with 3 doses of intranasal naloxone without, what is the appropriate duration of time to wait in between giving a first and a second dose? Dr. Plum.
Yeah, I think that is one of the big pieces, is that layperson inability or difficulty watching somebody get not better in front of them, staying blue, not breathing, waking up. People who have seen naloxone be administered and have that immediate come to, and when it doesn't happen, there's absolutely that piece. I think I heard of one account in a syringe service program that we operate where a person was describing how they had been revived and that 6 people got them all at once with injectable doses because they were all right there, which part of me cheered that there were that many people equipped, but then also made me kind of have to take pause about how important it is for us to be clear about give them a dose, give them 3 minutes. I think also when someone's been down a significant amount of time, the inability for perfusion to get the naloxone up to the brain is probably part of it as well. So chest compressions in someone that is not perfusing, there's potentially a role there for people to know about.
Right. I think recommendations are changing. The importance of naloxone certainly is critical, but ventilation in this patient is really what's going to save their life. And then, like you mentioned, if this person doesn't have perfusion, CPR, potentially. Patrick, you're out on the street and educating individuals about administration of naloxone. Tell us a little bit about your experience and what people are reporting.
We're seeing a lot of higher doses of Narcan having to be used. I personally had to use 5 4-milligram doses. They were spaced, 3 minutes apart. Ambulance was 25 minutes before they arrived. So we performed chest compressions, but the first 4 kits had no effect on her. The 5th kit, she popped her eyes open and got up and walked away. So we're definitely seeing that, street drugs are getting a lot stronger, and it's taking a lot more Narcan, I feel like, to bring them back.
Yeah, that's interesting. We'll look at a little bit about with some data on how many doses of naloxone have been required as we've had more illicitly manufactured fentanyl taking the place of heroin. In Rochester, New York, we do have a lot of pressed pills. Increasingly, we're encountering the Oxy 30s, or people call them the Perk 30s. And, how much fentanyl is in that, I don't know. So that we may have some cases where there truly is a really massive overdose. I've looked at some of the crime lab reports where the purity of fentanyl powder is about 5%. So if somebody has, 100 milligrams, 5% of 100 mil, that's a very high dose. That would be a high dose of a shot to begin with. But yeah, that could be. I've also, heard from many individuals that they've talked about reversing overdoses where, they've given, as Dr. Plum had mentioned, 6 people are around the individual. The first bystander gives it, someone comes down, another, they give it within a minute, and then EMS arrives, and police and EMS give it, so you got 4 doses within a very short period of time, and as we talked about, time goes fast. So one other question, how did fentanyl overdoses differ from heroin, diacetylmorphine, or even historically morphine overdoses? What's the difference between a fentanyl overdose and heroin? Dr. Nelson, we'll go back to you.
I mean, clinically speaking, there's really no difference. I mean, they both are really affecting you through producing ventilatory depression, depressed mental status, and all the other clinical findings you'll see. Obviously, the doses you need from fentanyl are significantly smaller to get the same effect, which means it's easier to give somebody more fentanyl relatively in a given volume of drug. So, I mean, the way they primarily differ, at least as overdoses occur, is that it's easier to take too much fentanyl than it is to take too much heroin, right? Just because of its exceptionally high potency and the need for tiny little volumes in order to get sick. There are also a lot of analogs of fentanyl. And I tell you, the problem, again, we hear a lot of people say there must be a potent analog on the street causing all of this irreversibility with naloxone. But if you dose fentanyl properly, meaning equi-analgesic or equi-rewarding or whatever metric you want to use, theoretically a fentanyl overdose should be equally as reversible as any other opioid. They should, its affinity for the receptor really isn't marginally different than that of any of the other opioids. And naloxone is certainly able to knock it, so to speak, off of the receptor.
Right. Yeah, the affinity is essentially the same as morphine. What I guess what I was getting at is fentanyl is extremely lipid soluble, so it's getting into the brain even quicker than diacetylmorphine, which is going to get into the brain quicker than morphine itself. So you have potential for more rapid respiratory depression, coma, so people can drop quicker. So the need to have someone there with the individual to reverse the overdose is critical versus somebody maybe coming back within a few minutes. And so I guess it from my understanding, it can occur more rapidly, but it's going to look just like a regular opioid overdose.
I think that's fair. And you know, because of that rapidity of rise, there is this syndrome that many people refer to as the wooden chest syndrome, or it goes by various different names, which probably has to do with the ability of this drug to affect the basal ganglia and other parts of the brain that are associated with movement. I think all of the opioids would do it. I just think it's a matter of, as you pointed out rightly, Tim, how quickly the opioid gets into your brain. So if I gave you morphine directly into your brain, it would probably look just like fentanyl. But since I can't do that usually, and I give it to you through your veins or orally, it's not going to have the rate of rise in the brain that fentanyl would have.
Well, I think we've seen that rapidity as well as fentanyl's gone out across the nation. The areas where it hit hard, the harm reduction programs, et cetera, would report how much more quickly people were going down, how much more quickly responses were needed. And when we used to think of, you know, you had an hour-ish with a standard historical heroin overdose, that it was more like a 10 or 15 minute scenario. And as fentanyl enters different markets or you know, geography, that same thing's been seen anecdotally.
Yeah, that's good. I mean, the classic down with the needle still in the vein is, you know, historically what people talk about. Dr. Bashevitz, is there anything in the Q&A or chats or anything that you'd like to add?
Yes. So there's an interesting question about what types of comorbidities might result in decreased sensitivity to naloxone. Are there any? And would COPD or emphysema affect this?
So that's an interesting question. What sensitivity to naloxone? Well, comorbidity, co-ingestion, certainly, I guess if you consider that a comorbidity, and we already talked about a little bit, hypercapnia, hypoxia, not necessarily comorbidity, but if someone poorly administers the naloxone, that's going to be a challenge. And, you know, they squirt it all over instead of getting it into the nares necessarily. It's not necessarily atomized. I don't know if anyone wants to comment. Dr. Holland, can you think of any? COPD, you can certainly have more hypercapnic response. So I think that's going to increase risk of overdose. We know what comorbidities increase risk of opioid toxicity, sleep apnea, things like that. But naloxone resistance, any other comments?
Yeah, no, I agree with you, Tim. I think if they're already hypercapnic, it doesn't take much to tip them over the edge. If they decrease your respiratory drive with opioid, and then if they COPD, so that would make it worse. And just a comment about the difference between fentanyl and heroin. In many areas, there isn't a difference because people are buying what they think is heroin, and it's fentanyl, or it's a little bit of fentanyl, a little bit of heroin, a lot of fentanyl. So I sort of a skewed thing because sometimes I get review of deaths referred to me from like prosecutor's office because somebody died from what was all fentanyl and was buying it from a dealer who told them it was heroin. And so they're prosecuting the dealer for the person's death. So those are tragic. And we've probably all seen that.
Mm-hmm. You know, Tim, I think that the better word for decreased sensitivity is decreased apparent sensitivity, because I don't think that the sensitivity is actually reduced. I just think that, you know, if you have a brain bleed or if you have a PCO2 of 100 and something like this person did, we're going to give you naloxone. It's not going to work to wake you up. It's going to still reverse the opioid at the opioid receptor. There's going to be no issues there. And actually that sometimes leads to problems, because what you'll wind up seeing, particularly in people who are like benzodiazepine intoxicated or alcohol intoxicated, they will develop precipitated withdrawal, right? They'll vomit and they can't protect their airway. And then they wind up having a pulmonary aspiration syndrome or something. So there is a certain danger in that liberal use of naloxone in an unselected population like that.
Oh, I agree. I mean, I see patients coming in all the time, either unmasking another toxic agent like cocaine, where actually the opioid was essentially protective. Certainly respiratory failure is going to be important to reverse versus, cocaine toxicity. That's going to kill someone first. But, there's higher doses of naloxone are going to cause more precipitated withdrawal, and aspiration is such a common occurrence. But, there's other complications, myocardial stunning, rhabdomyolysis. I mentioned, there's a question, what other lab abnormalities might want to expect in this patient? I would expect, so we've got hypoxia, acute kidney injury, lactic acidosis. I'd expect acute liver injury. I'd want to check a CK. I'm sure that there's going to be rhabdomyolysis. Trend the lactate. She's probably going to have leukocytosis, both from the stress response of the overdose, reversal of naloxone, and potentially from aspiration as well. It'll be interesting to see how this patient evolves. Any other, Dr. Connor, one question. You've been an embedded researcher in a group that's doing a lot of overdose prevention and distribution of naloxone. What kind of reports are you getting from the researchers, and what's your experience in learning about the naloxone use?
Much of my experience comes from you, working with you and working with Patrick Burns, who's our peer advocate today. I have some comments for a little later in the presentation, Tim, actually about some literature-based studies of naloxone distribution. So let me hold off till then to comment, but thanks for including me.
Excellent, okay. All right, so I've got a couple reasons. We've already mentioned reasons why naloxone may not be effective. And by effective, I don't mean that it's not reversing the opioid or knocking the opioid off the receptor, but by the patient or individual may not be waking up. We've got severe hypercapnia, as this patient had. Hypoglycemia. We recently had a case of hypoglycemia and a fentanyl overdose. I've seen that a couple of times now. Certain opioids are more likely to cause hypoglycemia, methadone in particular. There's opioid mimics. Atypical antipsychotics cause sedation, small pupils, quetiapine, even some of the older ones. Typically, they'll see tachycardia and some other effects. Clonidine or guanfacine overdose, xylazine, the course anesthetic, is now showing up more on in particular in the Northeast. Usually, it's combined with an opioid, but there are cases where it's been sold separately. That's an alpha-2 agonist as well. And then alcohol and sedatives involved that can reverse an opioid, but still have substantial sedative effects that won't be reversed. Polydrug overdose is becoming the norm, not the exception. Anoxic injury, there's substantial anoxic injury. The brain is stunned. The patient may not wake up. Head injury, as Dr. Holland mentioned, could be present. Seizure, if there's a stimulant there, or even precipitated withdrawal, it can cause seizures in and of itself. And then administration technique, potentially poorly. Any other reasons that any of the panelists want to add? Any comments or questions in the Q&A, Dr. Bishevitz?
Only other reason that I know it's not on the list, but we mentioned it could just be that it is a competitive antagonist. So there are those little mini outbreaks where they just put too much drug or a new drug into the pill or into the mix of the heroin, and you just can't reverse it. But I still think those are very rare events. Well, because it's a bad business model from a dealer's perspective to give so much drug out. It's not economically good, and you're killing off your patient, your clients. So clearly that would fix itself pretty quickly when that happened.
There is one opioid that has challenges in reversing the naloxone reverse, and that's buprenorphine, actually. Although in most of those, that's going to be you have a non-tolerant individual that gets a large dose of buprenorphine. So reversing buprenorphine due to its binding affinity, naloxone may be difficult, but that we don't see too often. Even in the pediatric ingestions that I've seen, naloxone has been effective in reversing those, but there is literature that suggests that buprenorphine is a challenge to reverse with naloxone. So we talked a little bit about this. Have you run into naloxone-resistant opioids in your clinical practice? That you can, other than massive overdose and potentially buprenorphine. And then the second follow-up question is, what are the risks of giving high-dose naloxone? We talked a little bit about precipitated withdrawal, but does any of the panelists want to add anything to that? Dr. Holland?
No, that's sort of.
Yeah, I think the only other risk potentially, I'm not sure it's really a risk, but it just lasts longer, and one of the nice parts about naloxone is it doesn't last very long, and particularly when you give it intranasally, I mean, it just lingers for a very long time. And once you precipitate withdrawal, the quicker it goes away, the better off you are. You start seeing people doing sort of atypical things like trying to reverse the naloxone by giving opioid, and then you paint yourself into a corner when you do that. So never a good thing to do. Giving sedatives, they give benzos or antipsychotics to take the edge off.
I think absolutely that is one of the big risks. The more naloxone you put into somebody, the worse that they feel. And then the inclination is to not feel worse again, right? And so in the layperson setting where folks aren't making it to medical facility to be watched, et cetera, if you're having worse withdrawals, if you're feeling worse, the next thing that happens is people use more opioid. And what an awful scenario, right? That you reversed someone's overdose with the naloxone that you had on hand, and then in order to not feel lousy, more opioid got put in place and puts them at risk of overdose again. And I think that we forget sometimes that within the medical sphere, at least, we forget how terrible that withdrawal feeling and that precipitated withdrawal feeling it is, and the lengths people will go to not have that feeling again, and the risk that comes with that. The other thing, the term naloxone resistant gives me kind of shivers every time I see it, because I just don't believe it exists. You know, the concept of naloxone resistance, I don't think exists. It's, to me, all about dosage and timing. It's about, did the naloxone get where it needed to get in time? I just don't believe naloxone resistance, and I'm glad you have it in quotes, because I don't think that it exists.
Right. No, that's why I put it in quotes. I don't have a slide on this, but there is a program in New Jersey. I believe Camden is one of the only cities that are doing this, where EMS and buprenorphine are offering buprenorphine after that have been reversed naloxone dose brings out of withdrawal. That's interesting. The data presented last year at ASAM, I believe about 10% of the individuals that were reversed with naloxone were given buprenorphine effectively, and so potentially an area that really has some benefit, but that's only implemented, as far as I understand, in areas of Camden.
Tim, I'll comment on that, and then I might have to jump off, unfortunately. But sure. But I think originally the idea was, and I don't know if Rachel Haros is on the phone where they're doing it, but I'm in northern New Jersey. She's in southern New Jersey. But I think what they're doing now is, if you get naloxone, they'll start you on buprenorphine. I don't think anymore they're giving you naloxone to start you on buprenorphine. They had done that in a couple of cases, actually. I think there was a little ethically questionable, you know, if people really understood what they were undergoing. But I think now the way the model works is that when EMS gives you naloxone and you're ready to bolt and not go to the hospital, because many of these people don't, then they enroll you in their buprenorphine program and get you an appointment to go to the treatment center.
Right. No, I didn't. I think they did publish a case report where someone requested reversal to get buprenorphine, but as you mentioned, it's reversing an overdose, not to give buprenorphine. But once they do reverse the overdose, they do offer buprenorphine to the individual at the scene by EMS. So there is this literature that talks about, is higher dose naloxone needed in the era of synthetic opioids? I've got one example of a paper, higher doses of naloxone are needed. And this paper, if you review it, really is a hypothesis generating paper. They describe scenarios based on animal models where theoretically naloxone would be needed to, a higher dose of naloxone would be needed to completely reverse fentanyl, high levels of fentanyl. The binding affinity is very similar between fentanyl and morphine. The difference is the lipophilicity, so the rapidity of the overdose is really what's different. So, someone going down quicker from a fentanyl overdose. There's reports of recurrent doses of naloxone being utilized, but when you actually look at the literature, there's a lot of variability in terms of actually are higher doses or more doses of naloxone being utilized, as illicitly manufactured fentanyl is largely supplanting heroin as the opioid on the streets. And I've got some research that describes that. And then they talk about precipitated withdrawal not associated with higher dose of naloxone, and have one or two case examples, which I really find problematic, because absolutely the higher the dose of the antagonist, the closer it is to the full agonist, the more dependent the individual, the worse the precipitated withdrawal is. And I think Dr. Plum mentioned, that in her experience, this dysphoria, you can get certainly severe clinical sequelae, but a severe dysphoria, panic, that leads the individual to really want to reverse that condition rapidly. So I really disagree that the higher doses of naloxone are certainly going to cause more severe precipitated withdrawal. And that is there have been deaths associated with that, all sorts of adverse outcomes. One of the examples that they used to support their hypothesis really wasn't a study of whether or not higher doses of naloxone were required to reverse opiate overdose or with illicitly manufactured fentanyl. It was just the primary focus was to determine if naloxone availability changed patterns of use. And they found that the total number of naloxone doses was variable in this population of only 70 participants. The median dose was 4 to 8 milligrams intranasally. So that there's some issues with some of the data, I think, interpretation. There is emerging literature showing no differences as illicitly manufactured fentanyl is increasing. In one study from Allegheny County, Pennsylvania, from 2013 to 2016, they found an increasing number of fatal overdoses related to illicitly manufactured fentanyl as it started to supplant traditional heroin. Of 1,072 overdoses, there was no significant difference in the amount of naloxone doses used to reverse overdoses, despite the increasing illicitly manufactured fentanyl being prevalent from 2013 to 2016. And then there's more recent literature from Carpenter et al. From Atlanta. They studied they pulled 837 patient charts from a single urban emergency department, 417 diagnosed with opiate overdose, and they looked at patients where they had a urine drug screen and looked at opiate positive only, opiate with fentanyl, and fentanyl only. They had 121 individuals, 28 with opiates only, 70 with opiates plus fentanyl, and 23 with fentanyl only. They had the enrollment flow chart, and you can see the relative administration by urine screen, intraosseous. Dr. Misperceptions is wondering, so intraosseous is a line into the tibia typically when you can't get an intravenous line, and from what I understand, very similar in dosing and bioavailability. But the interesting data is there was no difference in dose by urine drug screen result. Looking at the top graph is fentanyl only in blue, opiate positive only in red, and fentanyl plus an opioid, because there was a lot of heroin that both fentanyl and traditional diacetylmorphine in it. And you see no differences in any of the groups by dose in naloxone. And then the bottom graph, they combined the fentanyl with the fentanyl plus opioid and compared that to the opiate, and again found no differences in dosage of naloxone used by that comparison. So this is 2020 data from Atlanta. So going back to our patient, this patient had a CK of 12,000, a leukocytosis of 30,000, a transient lactic acidosis that was fairly high, but then improved over 12 hours, an aspiration pneumonia that was treated, a pulmonary edema improved over 48 hours. There's evidence of myocardial stunning, so global hypocontractility. The troponins were elevated, and that's probably why we saw the heart rate in the 90s not responding to the hypotension sufficiently. This patient required suppressors briefly, fluids, and the contractility started to improve over 48 to 72 hours. The patient starts to wake up over the first to second day, 24 to 48 hours. Fortunately, he was very concerned and ultimately was extubated on day 4 of buprenorphine. A microinduction had been started early in the course, and was able to be initiated while fentanyl and adjunctive sedatives were used for the intubation, and patient ultimately did well and left the hospital on buprenorphine. We've already talked about why do patients receive multiple doses of naloxone. Then time passes very quickly. There may be co-ingestions. And we've already commented on naloxone-induced precipitated withdrawal. Do any of the panelists have any other comments? I see we've got 11 chats. Dr. Misperceptions, is there anything else in the chat or Q&A?
Yeah, there's a question about would there possibly be any difference in naloxone success between fentanyl that has been smoked versus nasal versus IV? So the route of administration, would that have anything to do with naloxone success? I don't know how you'd know the route of administration very easily with most overdoses anyway.
Really, you're talking about bioavailability differences in the amount getting into the system, but so if more was in the venous system and then delivered to the CNS, you're going to have to use a little more naloxone. So really, that's the only difference. But other than that, there wouldn't be a difference in effect. Dr. Sullivan, do you have any additional comments?
No, I don't think so. I mean, with regard to that question, I agree. I really don't think route really plays too much of a difference, since receptor affinity is what it is. And, I've seen some naloxone-induced precipitated withdrawal. And, certainly this image of these people flailing around and becoming semi-psychotic is what people think. But in my context of seeing it, that is not what I see. You might see some of the lacrimation and agitation and maybe some of the GI things, but that can be treated, especially maybe with rapid giving of buprenorphine. And, I'm not to say that these things never happen, but I do think that it's something that is kind of this mythological thing that we think happens quite a bit and often. And with the normal appropriate dosing of naloxone, it's just not seen to the degree I think that sometimes people think that it might be.
Certainly, and that leads me to another question. What is the difference between naloxone administration in the emergency department or in a controlled setting compared to, out on the street? Dr. Holland, do you want to comment on that?
I'm sorry, could you ask me again?
How does naloxone dosing in the emergency departments, where you've got a controlled setting, or the hospital, compared to somebody you found down, like an individual in the street?
I think we've already, kind of touched on that, but people kind of panic if they don't see Dr. Plum especially addressed that. When people panic and just keep giving it because they don't see instant results. And I think that's a way of getting, and then like Lewis said, when you start putting a lot in the nasopharynx, and then it just accumulates there. And then you have this depository that's going to continue to be absorbed for a while. So I think that people definitely, bystanders tend to panic more.
Well, and the programs that have gotten out injectable naloxone for decades that have used the 0.4 milligram dosing injectable, over 1 million plus doses last year through those programs. There is that difference in dosing in that, they start with 0.4 intentionally with the hope that we just can get breathing going again while EMS hopefully is en route. And also with the hope that, people come out less combative, less aggressive, less feeling lousy. And I know in the ED, and I just work in the PEDS ED, but they'll do the 0.1 per kilo thing and be hitting someone with 2 milligrams right off the start. So there is a touch of difference in dosing there, depending on what somebody has, but otherwise I don't think there's a huge dosing difference.
Well, if I've got somebody in a controlled setting that's drifting back into sedation, I usually have the 0.4 milligrams diluted in 10 milliliters, so deliver a 0.04 milligrams of naloxone every 1 to 2 minutes to just titrate the individual, just to gently wake them up. And it usually is 1 to 3 doses of that to get the patient to the level of they're now awake, they're able to ventilate. We can avoid the development of hypercapnia, and you can even wake the most heavily dependent individual without precipitating withdrawal. And I think that's really important to do in a controlled setting. Certainly the street down, not breathing is not you're not able to titrate like that. But once somebody gets to the hospital, you have a lot of nuanced dosing that you can do quite safely without causing the dysphoria, in particular if there's a long-acting opioid and the patient has got recurrent effects.
I love to hear that, Tim. I wish we could clone that in all of the settings all across the nation, because that's so spot on. So thank you for bringing that to people's attention.
Yeah, and that shows that your experience and expertise makes a big difference, Tim, because there's not a lot of people that would understand that. Yeah,
in a controlled setting, I think, where you have the monitoring, you can see what the oxygen level is, and that's a big difference as well. So thank you. I think in the interest of time, unless there's anything else from the panelists, we want to move on to the second case, which is more of a discussion about naloxone and distribution and associated support. Is there any final comments regarding case one? Anyone panelists want to make? Okay, well, we'll talk about getting it out to the hot spots. So we've got a street level recovery program that does an awful lot of activities, not just distributing and collecting naloxone, distributes and collects syringes that have been discarded, but distributes naloxone in areas of town with extensive street level drug use and high overdose rates. And so we'll talk about strategies for distribution, syringe collection, and other harm reduction activities. So just a general case, on a weekend, rounds to collect syringes, distribute naloxone, provide other supports in an area of an urban center plagued by heavy street level drug sales. An individual living next to a check cashing place asks for as many Narcan kits as you can give me. So what is a typical naloxone distribution strategy in an area like this? And, you know, how would you distribute, you know, like, how many kits are you going through? I'll talk to each of the panelists. And then again, during the same week, a hotel manager asked for about 20 kits because he's regularly using 1 to 2, sometimes more each night. So when you have these requests, what are your responses? And we'll talk to Patrick. You're the naloxone overdose prevention director. So tell me about your experience.
Typically, the way we do it is we have a team that goes out into the street. We have a team that stays back at our outreach location, which has every harm reduction supply that's available to us. And then our team on the street goes out with Narcan, harm reduction supplies, food, clothing, and stuff, and distributes it right to the hotspots, to the abandoned buildings, the abandoned warehouses, the homeless encampments. We're going right there on the street to them because a lot of the times we see that the stigma involved with substance use keeps people from getting naloxone or clean needles and stuff. So we try to bring the stuff right to them, and we're seeing that building these relationships. Now we're getting them to start to come into our outreach facility, which really helps because then we're in a controlled setting where we can sit down with them and talk to them and actually plant that seed to try to get them to move to the next step, not just, you know, continuing to get the harm reduction supplies, but to actually, you know, start thinking about treatment.
Yeah, that's great. So would you, you know, for the hotel manager and this individual next to the check cashing place, how many kits would you give? Would you?
As many as they wanted. Yeah, as many as they wanted. This year alone, we've given out 5,900 Narcan kits, and most of those went to people like this. Hey, I need, 10, 15. Rochester Transit, they get 100 from us at a time. So we do have groups that come get these large orders, so to say, of Narcan, and we absolutely give it to them. The more Narcan on the street, the better chance that it's going to be used to actually save somebody.
Yeah, that's great. There's many models for naloxone distribution, and this is a cut from PubMed. Take home naloxone from the emergency, intermanagement of the opioid overdose, nursing distribution, and a little bit about the laws mandating naloxone, and certainly New York State has a law allowing for prescription through the pharmacy, just in individuals able to pick it up. But the laws and coverage vary by state, but many states have made naloxone widely available. And there's increasing community level distribution in many urban centers in particular. It's the rural areas where it can be a little bit difficult. This is a slide I think, Dr. Connor, you added. Do you want to comment?
Yeah, I wanted to talk about a couple novel ideas for distributing naloxone or programs. So this was a study in Philadelphia. It was done in the Kensington neighborhood of Philadelphia, which is a setting where there's a lot of opioid use and overdose risk. Basically, what the investigators did was they distributed an app as well as naloxone kits to 112 volunteers, which were about half and half people with experience using opioids and about half community members who were concerned. And over a year's time, they tracked how many alerts that were put out through this app. And basically the app alerts other volunteers who may be carrying naloxone about an overdose event. And the app also connects to 911. So essentially these 112 volunteers were had their app with them by virtue of having their phone with them. And there was less compliance in the volunteers with carrying naloxone. But these individuals came across 291 overdose events. About 2/3 of those events were in the street, about a quarter of them were in people's homes. And in 25% of the cases, one of the volunteers administered naloxone prior to EMS arrival. And then in 8% of the overdose events, a person who was alerted through the app came to the scene and gave naloxone on the spot. And in about 53% of the cases where naloxone was distributed by a volunteer, that naloxone was given to the person who had overdosed more than 5 minutes prior to EMS arrival. And there were a number of lessons learned through this pilot study, including that people are more willing and more interested in having an app or carrying an app than they are interested in having naloxone or carrying naloxone with them. So through an app like this, there may be the capacity to alert other individuals who are carrying naloxone to arrive on the scene fairly quickly and begin to initiate naloxone prior to well before EMS arrival. So I know that these investigators, it's a collaboration between public health scientists at Drexel and computer scientists actually at Michigan and in Israel are looking for more to take the next step with this project. And then if you want to go to the next slide.
One quick question. So was
Sure.
this app triggered then if there was lack of movement, or was it triggered to certain biometric or linked to biometric data, like the heart rate slowing down, respiratory rate slowing? How did it signal? Not
that I was able to discern from this article, Tim. Not that I was able to discern. It's simply a vehicle to push out an alert to other volunteers in this network who may be carrying naloxone to come to the scene and to alert 911. I think, though, the short answer is there could easily be strategies to improve the app or make the app more sophisticated to get the kinds of questions you're asking. Maybe even given the panel's discussion, maybe even to provide guidance to the individual giving naloxone around spacing the dosing appropriately and titrating the dose appropriately, because it sounds like that's a major issue. And so I would think the app could be trained to do those kinds of things. Those are interesting directions. Yeah.
Yeah, no, I am aware that there are apps where one can either connect with a volunteer that, would then call 911, Good Samaritan law, would hopefully be in place, but then alert, if there was no response. And then there are other apps where the individual can enter that they are using, and that the phone would then trigger call to 911 if there wasn't movement within a certain period of time or other data. So that's what I was wondering, but that sounds like it's a little bit different. And so your next slide.
Yeah, this is a simulation study by Keen and colleagues. So these are another group of public health experts, and they actually don't have data, but they did a simulation based on available data in the Pittsburgh area, where they basically asked the question, what is the most efficient way to distribute naloxone in the community so that it would prevent overdose deaths. And the long story short, they concluded that that increasing the number of distribution points has some impact on reducing risk within an area or a neighborhood. But the much more efficient strategy is, at least conceptually, mathematically, according to them, is to give multiple kits to individuals who are interacting within drug use networks. So, similar to what Patrick was saying, that rather than increase distribution through opening up 10 distribution points in a community, a more efficient strategy would be to have a single point, but that the individuals receiving the naloxone receive multiple kits. And then there's some sort of strategy to support them or reinforce them in distributing those kits within their network. And basically their simulation strategy suggested that, basically empowering people to redistribute kits within their network is a much more efficacious way, cost-effective way to penetrate a neighborhood and get kits distributed, and ultimately to lower mortality in an area. Now, this is a mathematical idea, but it's an interesting one that one could study systematically.
We have I'm sorry.
Go ahead.
One comment. We've actually started giving kits to some of the larger drug dealers in the area and have convinced them to hand them out with the bags that they sell. And I don't know who said it earlier, but you don't, like we explained to them, you don't want to kill your customers. It's a business thing, but for us, it's just to get the Narcan on the street. But we have 2 or 3 of them that get about 50 a week from us and hand them out.
Yeah, it's that concept of saturation of community, right? Like it truly is about how do you get the most kits out and saturate a space where there to be potential risks. And for us, it's the same thing. Patrick and his crew have absolutely nailed it. Get out into the spaces where you can reach people, because they may not be comfortable coming to you or to other places. And we can set up all of the health department locations we want. We can make it available in all the pharmacies we want. Those aren't enticing places for people who are at risk of overdose. And if you can get somebody that lives and exists and is a part of a community, 100 kits, I will guarantee you those 100 kits will save more lives than the 100 kits on the shelf of any institutional space. So the mathematical model, essentially, even though I was kind of like, what, a mathematical model? It actually nailed it. Like, get it into the hands of the people who will get it into the appropriate hands of the people.
Yeah, that makes a lot of sense. And thank you for bringing that up. Dr. Bishevitz, do you have anything in the chat? Do you want to comment on your experience? I know as naloxone was first becoming available, Strong Recovery was one of the programs that was doing the overdose prevention, and you can kind of describe your experience as things have evolved and become much more widespread.
So I wanted to point out, especially with what Jennifer said about the naloxone distribution article, it's an interesting mathematical model, and certainly people have been doing this informally forever. We weren't really supposed to give it out to people, to give it out to other people, but sometimes they asked, I have a spouse at home who also needs this. Can I take 2 of them? And that kind of thing happened. Or they'd come back later and they'd say, I gave it to my friend because that's who really needed it. So this has been very interesting to watch over the years. But I really liked Patrick's idea about the giving it to drug dealers, because if you can even turn a few drug dealers to the idea of giving kits along with their merchandise, maybe someday drug users will perceive this as what business calls a value-added service, so that they might go to those drug dealers preferentially and end up increasing their business in some way.
That's great. I like that, the value-added service. Excellent. any other comments from the chat? If you haven't looked at the chat, there's some good comments about earlier questions and mechanisms from some of the attendees as well as the panelists, and it should be available to all of the attendees. So I've got some, just the title of the poster from Dr. Plum. If you wanted to explain, you presented this at the North American Congress of Clinical Toxicology, I believe. So you want to describe your experience on the injectable naloxone rescue kits and syringe exchange services?
Sure, and without hopefully taking up too much time, because I know we're wrapping up here, but we furnish, Utah Naloxone furnishes injectable naloxone kits to a number of partner organizations who also provide syringe exchange services and harm reduction supplies across the state of Utah. And we had participants report to those programs, or they, I should say, reported to the programs, and had 3,088 individual reports of naloxone rescue kit usage over a 50-month period. This was in 2017 to early 2021. We had full data points on about 1,356 of them. And what we determined, so these are the 0.4 milligram injectable doses, was that 98.7% of the reports described a successful reversal and a survival. Typically, the report of use was on a friend or acquaintance. That was about 73%, self 10%, stranger 6%, family member 6%. Spouse 1%, or unknown 5%. So typically it's a friend or an acquaintance around you. And the number of intramuscular 0.4 milligram doses used, in 30%, it was 1 dose. And in 51%, it was 2 doses. So 81% of the time, 2 doses was enough. Then there was 10% using 3 doses, 6% using 4 doses, and 5+ doses was in 2%. In that time period, there were 17 unsuccessful reversal reports, and those were reported to have used between 1 and 4 vials of naloxone. I think that one of the most interesting findings for me was that only 36% of the time did they call EMS when they were using a layperson kit. So you know, here is a strategy where it is crucial that these folks are using kits on the people that are around them, their friends, their acquaintances. 2/3 of them are not calling EMS. If they did not have naloxone, that person would not have made it. And it also spoke to me that this kind of hype of we need to get 8 milligram doses, it's going crazy out there. It's pretty unsubstantiated from what we have seen in the field with the partners that we use. And these are directly with people who use and inject drugs.
Yeah, so some great comments, and if you don't mind, we can include the entire poster with the slides, so attendees, if they're interested, if you're willing to share that.
Absolutely.
Okay, great. We've got about 2 minutes left. There's a comment I saw from Dr. Vikas about how you built the trust of the dealers so that they would allow you to give them naloxone without worry that they would be reported to law enforcement.
You know, part of my experience is 22 years addicted to heroin and meth. So I've bought from a lot of these same dealers when I was using. So our agency is known for, we're not a crime reporting agency. That's not what we do. We don't call the cops. We don't report crimes. We're there to help the ones that are struggling. And we kind of sold it to them like, listen, if somebody dies from something you sell, it's going to look a lot better if you're giving out Narcan than if you're not. And that was pretty much all it took. You know, nobody wants to go to prison the rest of their life. And the thought of handing out Narcan to help that seemed to be the straw that broke the camel's back, so to speak.
Yeah, great credibility and rapport. Just so some of the things that are offered along with the naloxone or clean injecting supplies. We've been working with one of the groups that is a syringe exchange to also provide clean syringes, cottons, cookers, educational material about overdose prevention, clothing and food. Some programs are developing wound care, basic medical care, bringing it to the street rather than, you know, individuals required to go to the hospital. A lot of cellulitis and soft tissue infections that are, you know, could be prevented early. Rapid linkage to treatment in some settings, depending on support staff and resources, and then the peer contact support is, you know, many of the individuals Patrick's working with are certified peers, recovery coaches, And then other services, cleaning up the syringes. I don't know how many syringes weekly Recovery always cleans up, but it's just simply astounding that, you know, the public health support. And then, you know,
this year, 43,000. 43,000.
That's in one area of Rochester, New York. Yeah. And then, you know, cleaning up, boarding up houses, and, you know, a lot of other supports, community events as well. This is just I want to give a shout out to Recovery Always. There's some other peer groups in the area as well, but this is the group that Patrick is overdose prevention coordinator, and Stephanie Forrester is developed this. So we got a lot of mostly peers, I believe, and people with lived experience doing a lot of good in the community. Yeah. So we are essentially out of time. I know that we can talk longer, but my two final thoughts are from Ralph Waldo Emerson, who lived from May 25th, 1803 to April 27th, 1883. And so what is success? To laugh often and much, to win the respect of intelligent people and affection of children, to earn the appreciation of honest critics and endure the betrayal of false friends, to appreciate the beauty, to find the best in others, to leave the world a bit better, whether by a healthy child, a garden patch, or a redeemed social condition, to know even one life has breathed easier because you have lived. This is to have succeeded. And then the second one is, write it in your heart that every day is the best day of the year. He who owns the day, no one owns the day, who allows it to be invaded with frets and anxiety. Finish every day and be done with it. You have done what you could. Some blunders and absurdities, no doubt, crept in. Forget them as soon as you can. Tomorrow is a new day. Begin it well and serenely, with too high a spirit to be cumbered by your own nonsense. This new day is too dear, with its hopes and invitations, to waste a moment on the yesterdays. I think very pertinent given what we talked about today. So the next case conference, we moved January to the second week. So we have Friday, February 4th as the next case conference. And a reminder about the American College of Medical Toxicology virtual conference registration, and the New York Society of Addiction Medicine virtual conference in February 11th and 12th. So please take a look. We'll include registration information for those that are interested as well. And we have these recorded and embedded both on the ACMT and the ASAM website. Please send feedback and comments. We take those seriously. And thank you all for attending, and have a great weekend. And I want to thank the panelists as well. It's a great discussion. Thank you all for joining.